is usually seen. One of the complications that can occur with this medication, which is very, very, very important for us to avoid, is that what they put in the patient's back, so this is usually seen more with an epidural, but what they put in the back for an epidural is a little piece of tubing that's about the consistency, slightly smaller than an angel hair pasta noodle, and it's kind of placed in that space. It's so small that it could navigate into a vessel, and the medications that we give in a epidural are usually, for my hospital, it's ropivacaine, which is a numbing agent, and fentanyl, which is a high-powered narcotic. So if those medications happen to migrate into a vessel, then you would be giving them IV, and the patient would go into respiratory and cardiac arrest. So they do make sure during this procedure they'll do something called a test dose, and they actually put medication in the epidural that has epinephrine in it, so that if they're in a vessel, it will cause a systemic response and the mom's heart rate will go up significantly to let us know that they are in the wrong spot. So the test dose, if the test dose is positive, that means their heart rate went up significantly. If it's negative, that means that it stayed the same. So you want a negative test dose. The spinal is the same process as far as the nursing care. It goes in a slightly different area, but it's the same process as far as the nursing care, except for the spinal is a one and done. They put the needle in, they give the medication, the needle comes out, there's nothing left in the body. With an epidural, they put the needle in, they thread a catheter, the catheter stays in the body and gives them medication continuously during the labor process. So with an epidural, you are going to have that catheter taped to the back. It's not sutured in. So that would be the difference there. The spinal is going to make them numb. The epidural should make them comfortable. They can still feel pressure, but they should not feel pain. Once we get through the active phase, we talked about the transition phase of labor. So during that, it's going to be preparing for the delivery. So getting all the equipment. So you can kind of see on the picture there, there's a lot of equipment that we have for a vaginal delivery. And then you're going to need the appropriate staff as well. So that's going to be the labor nurse, the support person, nursery, healthcare provider needs to be there. That's a big one. We don't like to deliver babies in labor and delivery by ourselves. We'd rather have the doctor there. And then if there's certain circumstances, like if this is a preterm delivery, you may have respiratory staff there, or if the strip looks really bad, you could have additional staff as supportive to make sure that we do whatever we need to as soon as that baby is born. So you could have additional staff as well. Most of your deliveries are not attended by the anesthesia personnel because there's not any need for them to be there unless it's a C-section. So if it's a vaginal delivery, they are not usually in attendance unless we just need them there. For your stage 2, this is going to be complete dilation to the birth of the infant. It usually lasts no longer than 2 hours. So I always tell students that if the pushing phase of labor lasts more than 2 hours, you probably have a round peg, square hole kind of situation, and we need to possibly investigate other delivery methods because we want to do everything we can to keep mom and baby safe. So stage 2 starts at 10 centimeters dilation. It ends with the birth of the baby, and it lasts no longer than 2 hours of adequate pushing is usually what we will go by for that. If they have Pitocin going at the end of stage 2, so after the baby delivers, you will turn the Pitocin off. So if this was a patient that was an induction and they are laboring and they deliver, then the Pitocin gets turned off for a brief period of time. Once the baby delivers, you're going to enter stage 3. Stage 3 is going to be the delivery of the placenta. It should not take any longer than 30 minutes for this to occur. If it's longer than that, then we worry that the placenta may be retained and they're probably going to have increased bleeding issues, so we may have to do additional procedures like a D&C to get the placenta out. That usually rarely happens. Most of our patients deliver their placenta without any issues. And most of the time, the mom may feel it a little bit, but it's not like delivering the baby. So they are usually loving on that little baby boy or baby girl, and so they don't really care about the placenta being delivered. So stage 3 is going to be at the end, once the baby's delivered, till when the placenta delivers. Usually only takes 30 minutes. After the placenta delivers, then you can start your Pitocin back, but instead of being very given small amounts, we give a bolus of Pitocin after the placenta delivers. Okay. There are 3 signs of placental detachment to kind of let us know that the placenta is about to deliver. So one of them is going to be lengthening of the umbilical cord. So it appears that the cord is getting longer because the placenta has moved down into the bottom part of the uterus. There's a big gush of blood, and it is a significant gush of blood. So if you do get the opportunity to attend a delivery and you see that, don't be alarmed, because when the placenta detaches, there is a significant gush of blood that occurs because that placenta is extremely vascular. And then there's also a change in the shape of the abdomen, but typically we don't really notice this as much because there's usually a newborn baby sitting on top and everybody's oohing and ahhing over the baby. But lengthening of the cord, gush of blood, and then change in the shape of the abdomen. Okay. All right, let's talk about some reasons that you might not get to have a vaginal delivery and may have to have a baby in a different way. So previous C-sections are one of the indications that we see for a C-section in a current pregnancy. So you can potentially have a vaginal delivery after a C-section, but there's some risk, and there's a lot of criteria that has to be in play before that can occur. So previous C-section, a lot of our patients just opt to have a repeat C-section because that can be safer for them. If they choose to try to have a vaginal delivery after C-section, we call it a VBAC, or vaginal birth after cesarean. They have to meet some criteria, so I'm going to briefly talk about that. So just write down the term VBAC, so vaginal birth after cesarean, VBAC. And these patients would only be able to have had one previous C-section. Their incision to the uterus would have to be a low transverse incision, so you can see that on that middle picture. It'll be the one on the top left. So they have to have had a low transverse incision to the uterus. And the reason for having a C-section the last time has to be something that has been corrected this time. So let me give you an example. So let's say you had a mom and she had a baby that was breech, and that's why she had her C-section the first time, but this time the baby is vertex or head down. That would be a possibility to have a VBAC. Let me give you an example of what wouldn't be. So let's say your mom had a previous C-section because she had a large baby that weighed 8 pounds, and we are estimating that this baby weighs 8.5 pounds. Then she's not going to be a candidate for a VBAC because her body's already told us that it can't accommodate a vaginal birth on a baby that size. So the criteria for a VBAC: low transverse incision to the uterus, only one previous C-section, and an indication on the previous C-section that has been corrected this time. Fetal distress is another one. If she had her first C-section because the baby's heart rate dropped, but the baby looks great this time, that might be a reason she could actually attempt a vaginal birth after C-section. Some other reasons that you might see patients have or elect to have C-sections: malpresentation of the baby. So breech is going to be butt first or feet first, so they can be frank breech, which means butt first. They can be footling breech, which means the foot's down. By far the most common breech presentation is going to be frank, which means their little legs are up beside them and their little booty's down in where their head should be. Transverse position or transverse presentation is going to be the top left one. So they are laying sideways, and it doesn't matter what kind of pelvis they have. A transverse baby is never coming out of a vagina because it can't. There's just not any physical way for that to happen. Now, if the baby turned, that would be a possibility. But transverse position or breech presentation would be indications for a C-section. It's just much safer that way. Abruption means that the placenta has torn away from the uterine wall before the delivery. So that is a medical emergency. It is life-threatening to mom and for baby, and that would require an emergency C-section. Placental previa we mentioned earlier, and that's going to be where the placenta has implanted over or extremely close to or partially covering the cervical opening, like in the picture in the bottom right. And that will be an indication for a C-section because obviously if we let them try to deliver vaginally and the placenta is sitting over the cervix, the placenta will deliver before the baby, and that is their life support. So that would be a C-section delivery also. A prolapsed cord is where a cord actually comes out of the body before the baby does and it gets pinched. So that would be another indication. Fetal distress, so absent variability with repetitive late decels would be an indication for a C-section. or labor just doesn't go like we planned it to. They get to 6 centimeters and they've been 6 centimeters for 12 hours and nothing we've done has worked, then it's safer to deliver by C-section than to prolong that labor. And then you can't even see C-sections done for complications such as preeclampsia. So a lot of the indications for C-sections are going to be your high-risk topics that you're going to cover in depth next semester, but at least you kind of know what they are so that when you see them next semester, it won't be a complete surprise. Just going to briefly talk about some things that we need to do differently for a C-section versus a vaginal delivery. For our C-sections, all of our C-sections are going to get prophylactic antibiotics within 1 hour prior to a surgical start time or the surgical incision. So they will need pre-antibiotics. They'll also get antibiotics for the first 24 hours post-delivery. So if they have a C-section at 8 in the morning, then they're going to get a couple doses of antibiotics after surgery as well. So they have to be stopped at that 24-hour mark post-surgery. Most of this doesn't necessarily apply, but it could to our patients about the blood glucose monitoring. So if they're gestational diabetic, we have to monitor that very closely. Surgery patients with appropriate hair removal. So it's very important that you get the terms right on this because it can be kind of tricky. So we do not shave our patients for surgery. So we don't shave their belly and suprapubic area. You're going to clip them. So you're not going to shave them, you're going to clip them. So shaving them, like if you shaved the skin on your legs or the hair on your face, a razor can actually scrape off some of the protective parts of the skin, which would increase their risk for infection. So we use a special clipper, which doesn't do that. So they can be clipped but not shaved. Urinary catheter removed on post-operative day 1 or post-operative day 2. So that basically is get the catheter out as soon as possible. So for our patients, it's usually post-op day 1. So the next day after their surgery, we go ahead and take that out. Surgery patients with perioperative temperature management, this means that we monitor their temperature very closely. So we know that patients that are cold don't clot very well and they have more complications. So it's the reason that we monitor their temperature so closely. Our ORs are kept at a lower temperature to help with infection control, but it's very important that we actively reheat them if needed to get them back to a normal body temperature because that's going to prevent complications in that postpartum or post-op period. If they're on beta blockers, they need to receive that. That's not usually something that affects a lot of our patients, but we do want to make sure that we do appropriate, and those last two should be together instead of separate. Surgery patients with recommended venous thromboembolism prophylaxis order, that's basically your DVT prevention. So we want to make sure that we're doing whatever is your hospital's protocol for preventing DVTs. Your pregnant patients and your postpartum patients are going to be higher risk for developing a blood clot. So for us, if they're a vaginal delivery, that typically means early ambulation. If they have a C-section, we put SED hose on them in the operating room, and those will be continued until they're up and ambulating. We don't typically give Lovenox like you would see on your med-surg units because obviously this patient's going to have a significant blood loss from the placenta tearing away from the uterus already. And your Lovenox can make that worse. So rarely would you see a patient get Lovenox that's a postpartum patient. It could happen depending on their history, but it's not one of our first actions. All right, so I'm going to go through and make sure that we hit all this. So they need antibiotics before and after surgery. They need to be clipped, not shaven. Their Foley catheter needs to come out as soon as possible. We need to make sure we're monitoring their temperature very closely and warming them if needed. They need to get their heart medication if that's appropriate for them. And we need to make sure that we are doing everything we can for DVT prophylaxis, which is usually early ambulation or SED hose if they had a C-section. During stage 4, this is going to be the recovery phase. You're going to monitor your patient very closely, assess their vital signs very frequently. So they're going to follow the same pattern that you would have seen with your perioperative. So that's going to be Q15 times 4, Q30 times 2, Q1 hour times 2, and then Q4 hours for the first 24 hours. And then it's going to be a little bit less frequently. We do know that most complications are going to usually occur within that first 24 hours. That's why we monitor them so closely. So I'm going to say that one more time. So vital signs are going to be just like you would do for a post-operative patient, and there's certain parts of your postpartum assessment that will be done that frequently too. So you're going to do it Q15 times 4, Q30 times 2, Q1 hour times 2, and then Q4 hours for the first 24 hours. You want to assess for bonding with the baby. You're also going to want to assist with breastfeeding. Breastfeeding needs to occur right after delivery if at all possible. The baby is usually very alert and receptive to feeding at that time, so it's important that we do everything that we can to monitor that and to assist with that. Common medications that you're going to see, most of these we've already talked about. So penicillin, that's going to be an IV, or it can be other forms, but in labor we give it as an IV antibiotic. Make sure you assess for allergies, especially because we do have a lot of patients that are allergic to penicillin, so make sure you assess for allergies. Oxytocin was the drug that we talked about to induce labor, so it causes contractions. It can cause too many contractions and cause fetal distress, so it's very important that that's on a pump, that it's monitored extremely closely and titrated based on what we're seeing as far as contractions and fetal tolerance. The biggest side effect that we see of oxytocin, other than too many contractions, is it causes water intoxication. It causes swelling, essentially. So the next morning after having oxytocin, they may look like a little Stay Puft Marshmallow Man, and that's okay. We did that to them if we gave them Pitocin for an extended period of time. Their body will start to diurese that off, but if they're having swelling after an induction, that's probably why. The bottom one's going to be Stadol, and the top one is fentanyl. Both of those are IV narcotics, and I think we talked about what you need to be familiar with as far as those. Some different medications. So these, we're going to just hit the high points as well. So your Cervidil is the picture that looks like a flat tampon right there in the middle. So that is actually a prep to induction medication. So it helps to ready the cervix for labor. So if they need some extra help in that area, that's a medication that we can use for that. So that's usually going to be used for a patient that cervix is closed and it's not effaced and their baby's not well applied to the cervix at all, but they need to be induced. So a Cervidil option might be given to them, and it just lays under the cervix and it releases medication for about 12 hours and helps their cervix to get ready for what's going to happen. The ephedrine that you see in the bottom left corner, that is going to be if the fluid bolus that we gave them for the epidural didn't work and their blood pressure dropped, that is the medication that we would use. That's all you need to know about it, is that it can be a backup to a fluid bolus for a low blood pressure after an epidural. That's all you need to know about it. Phenergan you've had before. It's going to be for nausea, so it may be used during labor. The two on the right hand side though, I do want to talk to you about a little bit. So Cytotec is going to be the one at the top. It can be used in small doses to induce labor because it causes contractions, but the most common use for it is going to be for postpartum hemorrhage. So if we're using it for postpartum hemorrhage, we typically give 800 micrograms, which is going to be 4 tablets, and we give it per rectum. If we're using it for induction, we usually give 25 micrograms, and we actually insert that into the vaginal area. So if you're using it for induction, it's a small dose given intravaginally. If you're using it for postpartum hemorrhage, you're going to give a big dose per rectum, because if you put it in the vaginal area, the blood would just wash it out and it's not going to absorb that way. So we'll talk a little bit more about postpartum hemorrhage, but typically the first drug that we would use for postpartum hemorrhage is going to be the oxytocin or the Pitocin, but Cytotec is usually our backup drug. The one on the bottom right, that is going to be Methergin. That's going to be the generic name that you see on the label there. And I put it on here because sometimes you'll see, I don't think you'll see it this semester, but I want to make sure it's covered in case you see it in the future. So Methergin is also used for postpartum hemorrhage. However, it cannot be used with a preeclamptic patient or somebody with high blood pressure because it can cause hypertensive crisis. So Methergin is a drug used for postpartum hemorrhage, but only if they are not preeclamptic, because it can cause some issues with that. Alright guys, that is going to be it for your intrapartum part of this. I know that was a lot. The good news is the postpartum and newborn usually goes much quicker. There's a lot of stuff in that antepartum and intrapartum. So this is going to be the end of your intrapartum, and I'll be back with your